Welcome, Alicia.
Thank you for having me.
A very warm welcome to Perth Dialogues. One of our common friends told me about your work when I was talking about something in health sector here. Uh, you would have heard about Ashwath in WA, where his daughter died, and we were talking about that death. And someone told about your work and your network, and said, "Go and just see what kind of work she does." So I was interested, and I started reading about your work, and I just couldn't believe, coming from India, like I've seen in India the kind of gaps the medical system has because of the huge population in India. But I never accepted or expected that in such a developed country with such high incomes, we'll have so much gaps in our health sector across Australia.
Yeah.
I'm in Perth. I saw your stories from Brisbane, New South Wales, everywhere. And that's where I thought of inviting you to the podcast to so people can get to know of your work, and especially the migrant community, because we come to expect that when we are here it'll be fantastic, and then you start realizing what it is actually. So again, a very warm welcome to Perth Dialogues.
Yeah, I really appreciate you having me on, and I guess to expand a little bit on that, we have. I mean, yes, I have founded Maternity Consumer Network, but I have the best committee of volunteers, and they are so passionate about helping, and including migrant families. My partner's a migrant, so I do understand those nuances and the conversations we've had. And, kind of explaining to me, when you come to a country like Australia, you just expect that you're getting this really high quality healthcare, but also because of those cultural nuances, you just do what the doctor says, or whoever the healthcare provider says. I guess if we look at, we can even compare, I guess, India to Australia. We've got a situation in a developing country, say India, for instance, but there's quite a few of them. It's called too little, too late, and often that is because of health system constraints. In a country such as Australia, often it's too much too soon. But a common theme that I am seeing in this space, the maternity space, is often the woman, but can be partner as well, not being listened to. And we see that, across the health space, but particularly in maternity care, there is a common theme of not being listened to, and that the same hierarchical structure, where it's like the woman's down here, and that the provider is telling the woman what to do. That seems to be very universal, no matter what country you're in, and it does. We have those same themes around the coercion, the bullying, those lies and kind of intimidation to get women to comply to certain procedures or to do certain things. That definitely seems like a universal trait, unfortunately, that's in maternity care as well.
What I've seen is I've seen a few child deaths in WA health system.
Mm,
Ashwarya is the biggest example, but there's a few
yes.
more. But
Mm,
only Ashwarya's father went up to that stage to shake the system. So my
mm.
interest would be, let's start with what made you start your own maternity consumer network, and what did you go through something, and then what made you go through all these years, 10 years now?
Yeah, I actually had really good births, and I grew up in a tiny rural community. And what I was seeing happening in the birth space was not, and I'm not saying this to be dismissive or anything, but if to me, growing up on a farm, I saw animals birth all the time, without intervention, without fanfare, all okay. So I had a very different lens even going into birth that was very like it should be uneventful and things like that. I actually then on the other side had good births, but it wasn't in line with what other women had been telling me. Their stories were like polar opposites. And I was a bit not just mortified, but really perplexed, like a bit like when you were saying to me, how in a country like Australia are we having these kind of outcomes? I could also see, though, too, that this space was very political, and as your friends were kind of realising that you need to get it in the face of MPs and the media to really get traction and make change. So I really focused on not just trying to provide support to women, because that is incremental in the change, and it's still reactive rather than proactive. So I really wanted to get political, utilise the media and really mobilise women to make policy and broad changes to impact as many women and families as possible. So my eldest is actually almost about to turn 17. I didn't start advocacy until I had my second. And again, I don't think I really understood it until my second, and then I could reflect and go, I had really good births, but there's so many women around me and family that aren't sharing that story. And so I just started doing a lot of volunteering. I was really fortunate at the time here in Queensland. I actually was teaching the health minister's kids. So I had a direct link to the health minister, and I'd be tapping him on the shoulder and I'd be, listen, like, this is not how it should be. Women should actually have a known midwife like that at a very bare minimum, that she can. Back then it was calling, we still had dial-up internet back then, but now it's, you should be able to text your midwife, to check in and things like that. So that really, what I realised was the power of conversations and having that access, and then of course utilising the media, but not just to tell poor outcomes. Like, absolutely those stories need to be told and it will make change, but also I like to also tell the good stuff when they are implementing those changes and providing that evidence-based and bare minimum care. Like, you shouldn't just be alive, you should also be well, and your baby and family well, as an outcome from accessing maternity care in this country.
Um, so you talked about the access to midwives. Is there any, like, two or three big issues that you see that are needed or to be sorted out today across Australia?
That would be one of my big ones. And it doesn't matter your background or where your health status is, having that known midwife is going to improve your outcomes. When we look at two migrant communities or First Nations communities, having that relational care and having that cultural sensitive training, or those nuances in culture, will help as well. The second thing I would say, and this is for families in often in rural, remote locations, as we've seen basically maternity deserts form. So we've decimated rural maternity services in this country and lost half of them since the 90s. So since I was a kid, and my family was born in the local rural town, you can't birth in that rural town anymore, but also it's happening like in the next town. So we've really centralised and almost herding women into the cities, which hasn't improved outcomes. So the second thing I would say would be around changing the funding. And we've never really asked for more money. We've actually said change the way that funding is delivered. So instead of the funding, like if you've got a bucket of funding and it's just going to like the type of intervention, so a caesarean birth's worth more than a vaginal birth, but also just the place of birth, you're missing out on a whole range of the care while the woman's pregnant, and then that care after that baby's born as well, because we're only funding it for where the baby's born, and that's only a small portion. Like, yes, it's important, but so is the pregnancy, particularly that after birth care. And then the third thing I would say is around respectful maternity care. And this could go across the board and just say respectful health care. But that, when we're reducing or say even increasing that uptake of respectful maternity care, the outcome of that is reducing birth trauma. And 1/3 of women have birth trauma in this country. And we also have high rates of PTSD. Most of that is care provider actions and interactions. So we can solve that by having respectful maternity care.
Yes, those are big issues and we'll come to it. But do you think in our health settings, we are going towards a monopolistic obstetric led model in hospital settings? That's the only form of healthcare you'll get in Australia.
It's very state dependent, and I do think that we are risking de-skilling our midwives, because midwives have a certain scope of practice, okay? They reach that scope and then they refer to the obstetrician. The evidence, and this is where it gets interesting, the evidence and cost effectiveness is actually in midwifery care. Even the World Health Organization is saying like it actually reduces mortality as well. But we do have, and this is where it gets political, we have a very medicalised system, and we have an obstetric workforce that is very powerful. So we are risking that. We've only got to look at outcomes, and this isn't even from an ideological approach. Like our outcomes are horrendous. We've got, I think, around 40% caesarean rate, which is ridiculous. Like I'm all for maternal choice, but you can't tell me that 40% of women are requesting a caesarean. We've also got really high induction of labour rate, and induction of labour is where women are given a drug to force on labour, so to force the birth of the baby. For some women, and it's only a small amount, for the health of them and their baby, absolutely. You know, we do need caesareans, we do need inductions. But the rates that it is handed out and dealt out in this country is far too high. It's beyond what any evidence says that is of benefit. So we've swung the other way and we're starting to cause harm through over-intervention.
I think the WHO recommends that the cesarean birth rate should be around 10 to 15%, and we have 35% in Australia.
Yep, exactly. Yeah, and it's interesting because you go to poorer countries and they can't even get to 8% because they don't even have the doctor obstetric workforce. And I've actually done a little bit of work with the World Health Organization and caesareans and just trying to get some kind of like baseline standard for caesarean care, which is often aimed at these lower income countries. But working with some women from across the globe, and it was absolutely horrendous. Like these women in poorer countries can't even access surgery, so they're dying. Whereas we're the opposite. We're overusing surgery, but we're starting to see the poorer outcomes. Like on the other side of that, women are having higher rates of stillbirth after cesarean. Like there are problems associated with it, like postpartum hemorrhage. Like when you have a severe bleed, there's a thing called placenta accreta, where the placenta starts to grow through the previous cesarean scar. So whilst it's great to have access to modern medicine, it's not great when it's overused. Like it's costly, not just from a money point of view, but it's costly for health outcomes for mothers and their babies.
Let's start from conception. Do you think Australian women have got enough education, and we are educating our girls and women of this whole process from conception to whole carrying the pregnancy, of what to expect, the kind of changes the body is going to go through, especially in the first one, and then the labor, then the post birth, and then recovery? Is there enough education there, or people are just scared of going into this?
I think there's a whole range. I think statistically, if you look, there's actually a lot of unplanned pregnancies, like maybe 40% in this country. Like it's actually quite high. So as far as preconception care, it's probably not as good as it could be. I think there again is a whole range as far as education, and perhaps it's almost information overload. I do know though, because of the over intervention, the high trauma rates, we've actually got a high rate of tocophobia, which is actually fear of childbirth in this country. And that is actually, so what I'm seeing is almost two ends of the spectrum. So on one side, women are thinking, I can control this more if I opt to have a cesarean. I'm going to avoid the trauma and the mistreatment. It's not always the case. The other side is women opting out. And so they're opting to birth unattended. So what's called a free birth is where you just birth at home alone by yourself. The outcomes for that haven't been great though either. You know, like in a country like Australia, you think when you've got access to medical care, why would you be avoiding it? But it's because of what's happening within the system. So I do think there is a whole spectrum there. Could we be doing better with education? Perhaps, but there is so much saturation with the education out there. Women are almost overloaded. I do think that the what's provided in the hospital system is totally inadequate. So if you're accessing the free hospital education, we don't even have a minimum standard. So it will depend on what that hospital's philosophy is. And they might educate you a little bit about birth, but are they educating women and their partners on their rights, like their rights to say no, the rights to, this is how informed decision making works, where I, as the doctor or midwife, are meant to give you unbiased information, give you time to think. You, as the woman, get to make the decision, and then you come back and, make your decision. I don't think there's a lot of that going on speaking to women. Women will often say, oh, I didn't know I could say no, or, those risks were never explained to me. I wasn't told. So I think whilst if we talk about, I guess, just childbirth in general, there is probably information provided by hospitals and services. I don't think it's comprehensive enough to prepare women for what's going on in the system, or their partners, their birth companion either.
You talked about two extremes. One of them is women preferring or opting for home births. Do you think we have adequate structural and policy support around home birthing in Australia?
Home birthing, absolutely. So it's quite different to free birthing. So home birth in Australia is quite regulated. So you actually are attended by two registered health professionals. So they'll be midwives in this country. They're quite highly trained, so they have to be what's called endorsed. So they have additional qualifications. They'll often have medication as well. So for things like if you have that postpartum hemorrhage and things like that. I've actually had two not free births. They were home births. They ended up unassisted because the midwives didn't get here quick enough because they were very fast births. But as far as their skill set, amazing. And if we look to that low risk cohort of women, they actually have really good outcomes at home because they're not needing intervention. And what they found in the low risk women, you go into hospital, what ends up happening, you don't need it, but you end up with intervention. Comparing free birth to home birth is quite interesting because the only commonality really there is place of birth. When you're free birthing, you're actually birthing without any qualified attendant. So you're kind of running the gauntlet. Women may rely on their intuition. It's a whole, again, quite a mixed bag of women that opt to do that. Some women will just do it for religious reasons and have a very strong faith in God and God's outcome in that situation. But again, some opt out because of fear of the system, and there's a whole range in between. That in the last, say, 15 years that I've been in this space, I've seen it increase exponentially. And I think some of that is as women become more aware of the outcomes of the maternity system. So it really is a reflection of what's going on in the system. Women are opting out and saying, I'm not having a bar of that, rather than anything else. Because women, when they've been interviewed and they've really ground down into the nuts and bolts of it, women, their first preference might be, say, a home birth, or I wanted a hospital birth, but I didn't want to be treated really poorly, or like I'd heard what goes on for some women in the system, so I've decided to opt out. So often it is avoiding perceived trauma, or that they've had previous trauma that they're not going back.
Right. I learned something. There's home birth and free birth. See?
Yes, yeah, it's different.
It is. It is. It's always learning, even though I have interest in medical field, so I like to learn. Um, I had two kids, and both were from cesarean. And there's a belief in India that doctors will push for cesarean because they can then make more money. The hospital stay increases, the intervention increases, the surgery is there, more professionals and nurses are needed for that thing. You talked about that we are seeing 30-40% cesarean births. Do you think the factors pushing towards the cesarean birthing is the same in Australia, that there's more money to be made, or even the policy settings itself are pushing towards more cesarean births?
I think it's definitely multifaceted, and I don't necessarily think it's as clear cut as perhaps what's happening in India, because I know a lot of these low income countries, it is mind blowing that there is like such a finite amount of resources financing these institutions, yet they have such high interventions. You're like, you know what, if you scaled that back and offered everyone a known midwife, you'd have such better outcomes and lower intervention. But you've also then got the cultural things going on there as well, whereas doctor knows best and I don't question, so I just go along with whatever's being told. I do think there is an element of it perhaps in the private system. See, our public system in Australia, those doctors actually don't get the money. They're on a set pay. So it doesn't matter how many caesareans they do, that's actually not translating into money, but the system itself will get more money for a caesarean. But as you said, a caesarean takes more. So it ends up, that women have got longer stays, you've got more staff as far as nurses and midwives caring for that woman and baby as well. I think there is a fear of litigation. What they did do a few years ago was called a caesarean atlas. They did it for a few health outcomes of women where they compared like for like, and it really was around postcode. So what does that tell me? It's about care provider attitude and perhaps the culture within that hospital, because we can't say that's a women's issue, right? Like if we're comparing the same cohort of women, so they're low risk women, so they're healthiest women, and all the babies are head down, so we're not having breech babies like where their bum or their feet are down. And there was huge variances, like I'm talking about threefold variances across postcodes. So that starts to, when you unpack it, it comes down to care provider attitude. So clearly in this country, we have some very perhaps risk averse or perhaps almost like trigger happy or scalpel happy obstetricians that are reaching for the scalpel very early rather than, let that physiological process of birth unfold. But I think some of how we move to improving practice is things like that caesarean atlas, but make it publicly available, make it very easy for women to see, because women will start to vote with their feet too. And we're seeing that already in the growth in private midwifery numbers. So private midwives are where you have that same known midwife. Some do home birth, some actually have hospital access. So you will just take your known midwife into the hospital. In the last 6-7 years, we've seen the population of private midwives double every 2 years. So like no other care provider in this space. Most private midwives are booked out and then some. So we've got this really uneven supply-demand situation. So I think that also says is that women will vote with their feet when they have that information. And often at the moment, it's coming from their peers. So they'll hear from a woman, oh, you know what? I had a private midwife, I had an amazing birth. Here's her number. So we're not, until we get that really transparent data in a way that's accessible to women, I think that will actually, like women will start driving the change more as well. And then we'll see more of a change in outcomes.
You talked about just now the woman choosing by walking. And you were involved in the birthing bypass issue in Queensland, where the women were forced to walk from rural to towns and towns to cities. Can you let us know what that was and the factors and how it affected the women and families?
Yeah, that was our second Bush Babies campaign. So because I grew up in a rural area, I'm really passionate about rural women having local access. But we also know that when we have rural birthing, it actually insulates the town as far as a lot of other health services. Like when you lose maternity services, you actually lose most of your services from that hospital, which a lot of people don't know. And they effectively just become geriatric hubs. So that particular campaign in central Queensland, we had a town, like a large town that actually also economically brings a lot into our state due to the natural resources that they mine in that area. But that was a town that had 900 women booked in. So I'm not just talking like a tiny small town like where I grew up, where there's not even 100 women birthing there. There were 900 women having whether antenatal, so pregnancy or postnatal care, once the baby's born. But 600 women alone were birthing there. 600, that's huge numbers. They had put it on bypass and were pretty much trying to force, so it was a huge bottleneck. forcing women to birth over 100 kilometres away at another rural town. Now, they didn't even have the facilities to take on an extra 600 births a year. So it really was diabolical. And I'm actually, I'm doing research at the moment on respect for maternity care, and I'm reading stuff from developing countries, like say India, where 2 women are having to birth on one bed, like resources are very stretched. We had situations where we had 2 women, so one was in labour and one might have been having a miscarriage in an ambulance at once. In Australia, in a very wealthy town in central Queensland. And it really, I guess, not just made me angry, but extremely disappointed at the disparities in the way that healthcare is delivered in maternity care across this country. So we ran about an 18-month campaign, and the biggest thing I will say to anyone that tries to run campaigns to improve services or whatever your area of interest is humanise it and tell the story. So every other week we had a woman's story, and unfortunately they weren't great stories. Like they were absolutely terrible and heart-wrenching, but that's how we got the change. And so we continued to do that. We had a really good relationship with the media. We were meeting with MPs, but the health minister took about 12 months to even agree to meet with us. And we got that maternity service back up and running. It was a huge job because we're all volunteers, but I would also say that is the power of the voter base as well. And people often forget and think, those MPs, they never listen. If you put enough pressure on them, they will have to.
You scared me because when my children were supposed to be, and my wife will say, it's the time. I'll get into a car and then we'll probably drive maybe 10 kilometers. And that was so much for me because I have to like rush and talk to the hospital. Here, the women were traveling 150 kilometers. I'm just thinking what was going through their family's mind and their mind. Because something can happen on the way.
Roadside birth, absolutely. But it's not just that. Like, you're in the throes of labour. This is like, labour can be quite painful. And I actually have travelled that road myself, not in labour, but just out of curiosity to go, what is the actual distance here? There is no way I would want to do that. It's not the best road. There's a range. It's There was a time it was flooded. It's quite a notorious spot too because of the high traffic for accidents. I just think it often seems to be the maternity space that always, gets shafted. I just thought how insensitive, but also just how disengaged they are from that cohort of people who are having children. You would just not do it to anyone. It made no sense at all.
And are these circumstances like peculiar to Queensland or that area, or is it like for most of the rural and regional women across Australia?
It's definitely across Australia, but particularly our bigger states. So we've never said we should have maternity services in every town. You just won't, because no one, as far as like a professional, they don't want to sit there and wait for, say, 2 or 3 births a year. Like, we do actually have to have a minimum number of births. But when we're getting up to, say, 100, 300 births a year from that population that they're then having to relocate, that is where we really need to look at reinstating birthing services, because some of these towns, this isn't just something, we're demanding to have maternity services. These towns actually had maternity services. So in Queensland, we've lost 40%. So we're, say we used to have 70 odd maternity services down to about 40 now. New South Wales at the moment, diabolical, an absolute mess. And to the point where there's stories of women being so that they're maybe in a rural area, maybe in a farm, heading to their local maternity service. Oh no, you can't birth here. And so they're driving town to town, trying to find something that's open and just being told, no, you can't birth here. I always think at a bare minimum, if we can't get a doctor, and this is some of the issue is staffing, if we can't get doctors, at least have midwives and proper transfer pathways. We have flying obstetricians, so they're in a plane, get them to these women, or get those women, chop it out. You can't say that having no maternity services is safer. Or in these towns where there are midwives, no midwives, you don't have the skill set to birth or to, work your scope of practice and make a call to transfer these women. We're going to make the women travel. It's not safe. It actually statistically is not safe at all. But it makes no sense when you've actually got some skilled staff there to be utilising those staff. And at the end of the day, women need to be able to make the decision. Do I want to stay here and birth with a midwife and transfer out if needed? Or am I just going to relocate? And most women would opt for A. It's a huge, not just physical and financial, it's a huge emotional burden that these families go through. Some having to relocate hundreds and hundreds of kilometres away from their support network, often family and friends and things like that, to have to birth their babies. It's not equitable, but as far as that financial viability, it's really just cost shifting back to the family and then blaming families as well. If they have a roadside birth, oh, you should have come earlier. Well, actually, no, you shouldn't have put the place on bypass or closed the local maternity service. So it's huge disparity. I think if we look at the healthcare spend for rural areas, and this isn't just maternity, this is just the general health spend. So if we compare metro per head to rural per head, there's about an $8 billion shortfall in rural healthcare spending. So imagine if those communities were getting that, how services would be transformed. And that may be things like just attracting and retaining staff. And we may need to invest in more infrastructure so these families have somewhere to stay. And as a teacher, when I go rural, there's often houses, so I have that accommodation, and I think we probably need to be looking at that for our healthcare staff too.
So you were talking about the issues of women and I'm surprised that going from home to the hospital itself is so hard, and they have to go from hospital to hospital to hospital.
Yeah.
Do you think, like I'm thinking this is the story or the case of Australian women, what do the women from different racial backgrounds and migrant women have to go through when you don't know the system, you potentially don't know the language, or you can't communicate that well to the system? What's your experience in this?
We actually did so on our committee, we've actually got Edwina, she's a bit of a data nerd, and she actually started extracting some data. And we actually looked at some outcomes of migrant women. And we decided just to compare two cohorts. So New Zealand women speak English, culturally very similar to Nepalese women. Now, the intervention in that Nepalese women's group was far surpassed New Zealand women. So absolutely, there are huge barriers, and I suspect in talking to women, they often get railroaded into interventions. There's probably racial profiling going on as well. Like we've actually had an inbox. There's a name that they actually call Indian women in WA that's very, very racist, but basically staff referring to Indian women like not being able to handle pain, being like princesses. So you've got that as well, not just that cultural barrier, but if you've got staff that have already racially profiled these women or these families, that in itself is going to result in poorer outcomes, whether that's trauma or what we're seeing is higher intervention. And there have been couples that we've worked with, some of our volunteers advocating for some very poor outcomes in migrant communities in Perth. And a lot of it is, I think that there's a racism problem within the health system, and it's certainly not all staff, but I think we need to call it out. Like we need to name the problem to start with, and then start looking at, okay, so what are the solutions? There's definitely a staff issue that we need to be developing more cultural awareness, and then within these communities, can we help, whether that's educate around like women, like what your rights are, and that it is perfectly okay in a country like Australia to be questioning what you're offered, and this is how informed decision making works, and things like that as well. But I particularly think that when I mentioned before having an on midwife, I think particularly for vulnerable communities and groups of women, that is what needs to happen as well. And I know for some cultures as well, it's often seen, like my partner says to me, being from Pakistan, he's like, Alicia, it's only the poor village women that would access a midwife. It's like in our world, doctors are the best. So you're also having to provide that education when I'm like, no, well, actually, it's got really good outcomes when you have a known midwife. That's what you want. He said, well, you've got like so much education to do in that space then, because that alone is a barrier when you're saying to women, it's almost insulting just to go and access a midwife because it's only the poor village women that would get that model of care. So that it's absolutely nuanced. I think there is a big responsibility on the system, because ultimately we pay tax. We should have a system that is fit for purpose for all communities within Australia. And then I think there's probably just some fleshing out of the cultural stuff and that education around, don't just accept what you get served up, ask questions, and things like that, I think would be useful as well. But that's to part of the health systems really engaging with those different communities to find out what's needed as well. And we don't do that well in Australia. It's called very standardised care. So what one person gets, we all get. Whereas we want to move towards individualised care for that woman and her circumstances. And again, that's why having a known midwife is so important, because she will develop the relationship with the woman, but she'll get to know your family and everything like that. But you also get home visits, which is not offered in a lot of other models of care. And particularly once the baby's born, you don't want to be jumping in the car and taking the baby to get weighed, to take the baby for the hearing test and a whole range of other things. You actually just want to be at home, getting to know your baby, feeding, getting up a million times a night and all those things without that extra chore. So it really is that wraparound service that is cheap, that we want all women and their families to be able to access.
I think coming from that thing, I think the midwife represents back home some elder woman or the woman from the same village who might help you through the labor.
Like a lay midwife, so not
Lay
necessarily
midwife,
trained, but she's
not a
got a, yeah,
exactly.
yeah,
And when
yeah,
you talk about midwife in Australia, it's a mid tier between a nurse and a midwife and obstetrics. That's a
yeah.
mid professional. So
Oh,
I think that's where
absolutely.
the miscommunication is.
Perhaps, yeah. And see, I didn't know that even when my partner's trying to tell me. Like he's like, if I was in, there's no way in Pakistan I'd be getting a midwife. But you're right. In Australia, it's actually a degree. So you train in a midwifery degree. And like I said, they have a skill set. They have access to medication. So prescribing, they can order bloods. So absolutely, that's probably part of the education as well. And perhaps from a health service point of view, like being very clear that in Australia, this is what a midwife does. And it's not because we're trying to like do things on the cheap. They're actually like have a skill set, and it's a recognised career. And that's not taking away, because I've watched documentaries on the value in some of these low income countries of these lay midwives and the skill set they provide. But it is, you're right, the same term but very different professional roles in different countries.
Um, Relating to this birthing issue, and there's social commentary around migration balance, where we're talking about migrant women, but in general, there is a huge population incoming from migrants, which is kind of balancing out the uh, low fertility rate or low child birthing rates in Australia itself. Uh, do you think uh, that relying too much on foreign migration is taking away the focus from getting the systems right, that women can have more child, they can have a good experience, which means that they can have not just one or two, they can have more kids. For in population replacement, our TFR is way below even replacement level.
Oh, I think it's 1.7. So absolutely, like couples in this country aren't even replacing themselves. I think it's multifaceted, but I will say it's very short-sighted and just to rely on migration to top up population. So you've got taxpayers for when we get old. It's very, very short-sighted as a policy and not looking at the longer term picture, because I think, like, absolutely, I think we're about 50% of our population at the moment is like first or second gen migrant. So we are a migrant country. There's no doubt about it. But at some stage, the migrants aren't going to be having one to two, like the two kids that are needed either. So it's just this constant. You're not solving the problem, and it needs to be looking at. I mean, what the problem is, they're not actually going to families and asking, but absolutely, birth trauma is a contributing factor. That's no denying that. Absolutely. Like if you've had such a traumatic first birth, you're not going to go back for a second. But we've also got a situation where we've got cost of living and millennials. I mean, I was lucky. I got into the housing market when I was 18. $70,000 my first house was, like, it was cheap as chips. Now, like, my eldest is 17 and I'm like scared because I'm thinking, good luck trying to get a house for under $700,000. Yet the wages haven't grown. So absolutely, we've got the generation who we want to be having kids who actually can't even afford what used to be the great Australian dream, where you'd get married, you'd get your house, and you'd have your 2 or 3 kids. It's just not happening anymore. It needs big thinking, bold thinking, but not quick fix policies. And I just find in the last few terms of government, it's just such reactive policy almost to the next election. We're not having big thinking, bold policies that are looking long term. And it may be things like, let's look at income splitting. So, because not all women want to go back to work. In fact, I would say there's a very large portion of women either want to work part-time or they actually just want to have a few years at home with their kids. We're in a situation where women can't do that. And it's not just that they have to maybe go back a couple of days, they're having to go back full time. And it is very stressful when you're doing 2 jobs at once. So raising kids and working full time. I think that they need to look at a whole suite of policies. It was interesting before the last election, I'd actually said to the shadow assistant treasurer, I said, you really need to look at income splitting. You do. Like, there are so many families that could benefit from that. And he said, oh, we can't afford it. And I thought, well, you must be able to afford to lose the next election, because something like this would be a real sweet spot for so many of those families that maybe don't qualify for maybe family tax A or B, so some of the Centrelink, but are in that income bracket where perhaps one, and it's usually, like, let's be honest, it's usually the father that is on the higher income. But if they income split, even if it was just okay for the, and once your youngest is 3 or 4, that's the maximum income splitting that you can do. And then you need to, I guess it's just forcing women back to work. But things like that, they really need to be looking at a whole range of policies. Even as far as childcare goes, institutionalising kids isn't a solution for everyone. I know in rural areas, we actually don't have access to childcare. So it's very metro-centric policies, the childcare policies and the childcare subsidies too, that it's only directed to childcare centres. So if you don't have access to it, you've got nothing. And in the past, when I've taught in rural areas, I actually had to rely on au pairs. So backpackers pretty much to come in and look after my kids so I could go and teach, because there was no childcare. So they really just need to get smart and bold and look at policies that are going to support families. And that way is the way that is the path to getting ultimately women, because they're the one carrying them, but to agree to have more kids.
When you were speaking around the total fertility rate issue, you mentioned something about birthing trauma. Uh, can you explain that, and then how it affects when women are having less children, 1 or 2, how that can affect of women not wanting to have more kids, that birthing trauma?
Yeah, so I guess if I loosely define it, because sometimes it will be a very individualized experience. But when I say birth trauma, it's very much big T trauma. Like it's a very traumatic event, not dissimilar to any other, whether maybe you've been in a car accident or you've been assaulted or something like that. Like women, some women will describe it like sexual assault because they've been totally violated. With that will come that psychological impact, which can be things like perinatal, so like anxiety, depression, sometimes PTSD. So it's quite profound. And when you're in that state that's quite dysregulated from the trauma, it makes parenting very hard because already you're like here, you're elevated because you've got mental health issues from the trauma. Your capacity to parent is actually decreased. Add another child onto that or another child onto that, and it is very, very difficult. And that's talking to psychologists. They're like, absolutely. If women have such profound trauma from their first experience, they're actually really looking at a second and thinking, no way. And I know myself, I've got friends that have had only one child, and they said, there's no way I would want to go through that again. So, yes, finance and the economics is a contributing factor, but I don't think we can dismiss when we've got 1 in 3 women having birth trauma um, that is having an impact, and they're just saying, no, I'm not. There's no way I'm doing that again.
1 in 3 is a big number.
Well, it's a patient safety and quality issue, and that's why I keep saying to institutions and even MPs, like, is there any other area of health where we would have 1 in 3 poor outcomes, and we would not go, hang on a minute, this is like a national crisis that we've got here. We need to address it. It's absolutely, it's so overlooked, and the long-term impacts, the cost of, and it's often borne by the woman, of her accessing the mental health support and things like that. But often then, and again, I'm just, from women's stories, the relationship dynamic shifts because you've got a woman who's traumatized. Perhaps she's felt that the partner didn't support her enough, or perhaps the partner's traumatized as well. So you've actually got a really then shaky relationship. Add a baby to that, and then you've got often relationship dramas, like big traumas and problems stemming from that trauma as well. So it's the domino effect is huge, and it's just not. I don't think it's taken seriously enough by policymakers and those in positions of power that could actually make change.
You were also talking about the social pressures on the woman, financial and otherwise, that they should go back to work faster. Then there was this big idol for women, the New Zealand Prime Minister, who was in the office within days of giving birth. Like when you have that kind of financial and social pressures, I'm thinking, does it affect the post delivery recovery of the woman, and then even bonding with the child? You need first 2 years to the child to grow back into wherever. That's the first 2 years are very important. Does that affects, or does it contributes to the birthing trauma, that there's so much push that get the child away, get back to work, or get back to wherever you were?
I definitely think that it can impact secure attachment. And by no means am I trying to throw shade on women who go back to work, because I see it. Like, I've got friends, and I see it in mothers groups, how forced they feel to go back to work. But I think socially there's also this, like, women who stay home feel like that they're getting looked at differently because, are you just a stay-at-home mum? So we've actually, as a society, really devalued just mothering. Um, I think there is overwhelming pressure to go back to work, but I don't think that it's what all women, in fact, I'd say it's not what most women want, going back to work so early. You raised an important point about those first few years, and I don't know the exact number. It might even be beyond 2. But I know there is some sociologists who've done research and who say, that secure attachment up to even 3, and that because even they don't understand about permanence yet, and you leaving them can actually be quite distressing for them because they don't know necessarily about time and are you coming back for me? Again, it's not about making women feel guilty. I think we actually just need to have these discussions out in the open and discuss it. And so what are the solutions? Like for those women who want to stay home, how can we best support them? And that may even be because I could tell you as someone who uses daycare, every time the government puts in more money for the subsidy, what do you think my bill gets like? It increases to the point the last subsidy, I didn't see that. I actually got an increase in fees. So the government's chipped in more, but then the centres I'm paying more than ever now for daycare fees. But for those women who want to stay home, is there any reason why the government can't direct the money that they're directing to the childcare centres to that woman? Because I think that is also another solution that is not well talked about that could offer women, and I'm saying women because let's be honest, like most care providing in those early years is done by women. I don't think we should get around the biological reality of it, that women have carried the baby. They need time to actually recover from the pregnancy and birth, but they also bear the breasts with the milk in them that we actually, typically have to feed the baby with. So I think we actually just need to also have those really frank discussions about the biological reality of it, that I even find it quite alarming how we're looking at splitting the paid parental leave, because even if we've got partners or dads who want to stay home, if we want these babies breastfed, and ideally we do, right, because that is, again, it's not a slogan, babies should actually have human milk. In that instance where we've got, say, perhaps dad staying home for whatever time, if that baby's to be still breastfed, it's the mother doing the labour to pump the milk to then leave for the baby for dad to look after. So we're in this roundabout way, we're still creating more work for women. I just think all options should be on the table if we want to actually get down to supporting women, yes, stay home, but also then that will encourage them, if they've got options, to think about having more babies as well.
I think you took away my idea, which was to not direct the money to the childcare centers, but give it to the mother. Let her decide what she wants to do with her time. Does she wants to take care of the baby, or does she wants to go to work and give that money to a third person to take care of the baby? Let her decide. She is the best person to decide. And otherwise, when you talked about paid parenting or taking care, like I can take a bottle with the mother's milk and give it to the feed to the baby, but the warmth, the touch, the oxytocins which come in, the hormones that come in, that's not gonna be there ever. I don't
No,
know.
it's totally different, and that's that attachment that, and it's just different. I mean, I see it, and it's not taking away from anything that dad's relationships with their children at all. But let's get back to biology, and there is absolutely, and I know even when they've looked at breastfeeding, like absolutely it's for sustenance and to keep the baby alive, but there is a hormone exchange and there are other things going on that a woman's body actually absorbs the baby's saliva to build up the baby's immune system. So the milk actually changes for the baby's needs. And that's not going to happen if we're pumping milk. Yes, the baby will get the milk, but it's not getting the feed, like the woman's body's not getting the feedback loop that it requires to actually individualize the milk, say if baby's sick or things like that.
Yeah.
You raise important points that all should be discussed. And ultimately, like if we're saying things are around women's choice, it actually needs to be true choice and not perceived choice, in that here's your choice of daycare. Like you've got different centres that you can send your kids to, but that's the crux of, or that's the limit to your choice. I think it would transform things for women.
You reminded me of Ford's quote that you can buy any car as long as it's black.
That's what daycare centre is at the moment. And I remember before it blew up with the like the pedophilia that's seems to be running rampant through our childcare centres, that there was always that, like, well, what happens if? Every woman has that in the back of her mind, no matter where she sends her kids. I even remember when I had au pairs, so backpackers from overseas looking after my kids, because I had no other option. All day in the back of my head, I'm like, I hope my kids are fine. I hope she's doing a good job with them. I think it is really dismissive and disrespectful of women and being able to make decisions, whether it's to utilise grandparents or au pairs in my case, or private nannies or whatever it is, because clearly we've seen that the government can't do the job to protect our babies and our children. So at what point do we give it back to families and say, you make the decision? Because I think that all families try to do the best for their kids, and we've trusted the government to deliver, and they haven't been able to.
Now that we are talking about changes and possible solutions, how does your network, Maternity Consumer Network, do this advocacy for change, and where do you see the most resistance coming from? Is it the health bureaucracy? Is it the hospitals? Is it the staff, the doctors, or is it funding models like you talked about, Medicare? Where does it comes from?
It's definitely multifaceted. So I guess from our perspective, a few things that we do is very much advocacy. So in Australia, we've actually got what's called a woman-centered care strategy. I think it's more of a mantra than actually a practice, but that's what it's called. So that's our national maternity strategy. So a big part of it is actually getting it implemented. We do a lot of education. So we've developed training for staff around respectful maternity care, and that's called Better Births with Consent, Better Birth Through Communication, and Perinatal Trauma Prevention. So I actually travel around with a human rights lawyer and a perinatal psychologist, and we go in and do that. Obviously, we help families and women. So we've got a dedicated volunteer who helps women make complaints and navigate through the system. And then that advocacy is very much political and through the media as well, and contacting, state MPs, contacting health ministers. And we've got a lot of states in Australia, and then we've got our federal as well. And we have complex funding that we've got private maternity, we've got which is, private, so through private health as well as Medicare. Then we've got our public health facilities as well, which use federal and state funding. So we've got a very complex system, which makes advocacy hard, because you'll get often bounce back and forth between federal and state MPs. And I'm like, no, actually, you're both implicated in this. You need to be listening, because it's actually, everyone's got skin in the game. I think as far as resistance, it is multifaceted. At grassroots level, it will be very much dependent on the attitudes and the culture within that setting. It's even state dependent. Because I've travelled the country running this training, I see, I find WA to be very, very medicalised. I would say probably 20 years behind the East Coast and what I've seen in the vast majority of Queensland, for instance. So it is very state and location dependent as well. And I think that's why when people do advocacy, it really needs to come from grassroots level, because then you're actually driving it in a direction that is suitable to what your individual community needs. And even within rural areas, there's going to be nuances, whether that's the demographics of women or just how they want their maternity service delivered. Yeah, so I would say there is no one level, but I do find, having a recent meeting with the Federal Health Minister's office, that they're very reluctant to make the states do anything. Now, if we've got this constant round and round, like the states are asking the federal government for more money, yet they're not delivering any better services, and the feds are like, well, we don't want to make the states do anything. Well, hang on, you're actually providing 60% of maternity services, and that 60% is actually taxpayers' money, and taxpayers are saying, we want you to do better, and you're like, oh, well, I don't want to make the states do anything. So we have this very convoluted round and round it goes. But ultimately, the federal government has a huge role in this because the amount of money that they put into it. So private health, they've got 30% rebates for anyone who's got private health. They fund Medicare, and then they're funding 60% of our public hospitals, which deliver the most maternity services, is actually state-based, our public health, our public hospitals. So I do think it really squarely sits with the federal government and their power to implement funding reform. I also think on the other side, we're not collecting the right data. Like, we have so much data in this country, and it'll be like caesarean and the baby's birth weight and whether the woman had an epidural and the gestation and all this kind of stuff. We're starting to collect some mental health stuff, but we're not collecting respectful maternity care indicators. Did the woman have consent? Did she feel supported? Was her cultural needs respected? And a whole range of things like that. You could do it in as little as 20 questions. That needs to be collected. Like I always say, my Uber driver asks for more feedback than any maternity service. That's the only way to drive quality improvement, is to ask a question and start publishing it publicly. We need to have transparency in those outcomes. So alongside caesarean and all those other indicators, what was the woman's satisfaction and respect for maternity care? Because that will drive improvement. Like, women will start going to the places that have the highest level of respect offered. But then we will have, like media being able to call it out too. Like, why has this place got such a low level of scores around respectful maternity care? And then point it out to MPs. So until we start collecting that side of things, I always say, like, data and transparency will help drive quality improvement. But to me, I don't think it's valued enough from policymakers. Like, this isn't something just I'm recommending. Their own policies, and when they've done reviews, their own reviews are recommending it, yet they're not doing it. But I think that's a big part of it too. Get the data, publish it, and drive quality improvement that way too.
I had some experience of working with consumer networks in health settings, and I understand there's such convoluted and slow pace the change process is, that by the time
Mm.
you reach the end of it, you have lost so many years. But sorry, you were going to say something.
Well, and that's often what happens too. So review gets released in year here. Implementation at glacial speed never gets implemented, and then 6 years later that review is not even relevant. So then we go back to consultation and review again. Nothing was ever done properly for the first one. So that's what I think is a big gap too. They do consultation relatively well. They do document, policy development relatively well. They do implementation and monitoring and evaluation poorly. And that's where they always trip up. So we just end up in this constant loop of consultation, publishing documents, consultation, publishing documents.
So I was going to ask that, in that setting and in that background, do you want to talk about any or the successes that you have achieved? Like, you had something in New South Wales. Do you want to talk about it?
Yeah, and I think credit where credit's due. Like, I will talk to it, but obviously I'm not a one-woman show, and I've never claimed to be. Like, we have a really awesome committee, but we did manage to get, so the woman-centered care strategy, which is like our overarching strategy, which again, we're still banging doors to get it implemented, but it was at request of, so we requested one of the previous health ministers back when Greg Hunt was health minister to do that. One of our volunteers, Amelia, she worked with a group of women in New South Wales, as well as worked with an investigative journalist. That was really the catalyst for the New South Wales birth trauma inquiry. Now, that Parliament inquiry got more submissions than any other inquiry that they've had. So we know that this is a huge issue for women. There's been various like we sit on or consult with a lot of state-based inquiries or guidelines or policy development as well. So I was involved with the Queensland birth strategy, and we just saw out of Victoria a respectful maternity care framework. And so we were involved with that. And again, it's great to be consulted, but a big part of what I keep saying too is, all well and good to consult, but I want to know how you're actually embedding this in practice so women are ultimately receive respectful maternity care or have access to an own midwife and things like that. So there's lots that we do across various jurisdictions, but it's often in partnership with women, definitely women and their families, but politicians and journalists too. Like, without that buy-in, I actually think that really is the magic mix for success. Have the women's stories, have them back you, have the political buy-in, and have the media have your back and be running those stories. And that's really been how we've gotten success and how we've had progress in this space.
You mentioned about the respectful maternity care. For people like me who don't understand this, what does it means? And you run something named like that, a training. Like, what do you give in that training on respectful maternity care?
Yeah, so I guess if we rewind a little bit of a history, so it came out back in 2011. So it's been out for a while, and it was on the back of a landscape report. So it looked globally at the disrespect and abuse of women in childbirth facilities. And whilst a lot of it was coming through from lower income countries, what we certainly know now is that this isn't just a low income country issue. It happens in high income countries too. But as a response to that report, there was a group of stakeholders, so maternity staff, human rights lawyers, consumers, researchers came together and developed. So if these are the corresponding themes coming through, so lack of informed consent, discrimination, abandonment of care, those kind of things, if that's the disrespect and abuse category, what are the solutions? So the Respectful Maternity Care Charter is actually 7 solutions, and it's pretty straightforward. Like, be compassionate, be kind, provide culturally appropriate care, make sure that you're providing informed consent. I often say that these aren't just clinical things, they're not just mantras. It should really be underpin everyone's, like, respect should really underpin everyone's moral compass. So it should be really a human characteristic, right? We're not just talking about maternity staff should have these as clinical, what would you say, clinical skills. They should just be every person's morals. But basically from that, here's how to provide respectful maternity care. It's then trying to embed it into practice. So our woman-centred care strategy actually has it as priority too. So the second priority of the strategy is respect and upholding that charter, but most staff don't know about it. So about 5 years ago, I was like, well, if staff don't know about it, I think part of my job is to let them know about it. So that training is really, I go in and I talk from a women's perspective. Like, this is what women are saying. This is what the evidence is saying. This is what, like, where data we're collecting is saying. But this is why we have the Respectful Maternity Care Charter. And so just taking them on that journey, like, this is why you should be doing what you're doing, as in providing respectful maternity care, because this was called out, this, mistreatment of women. This is the solution. They're often really interested in what the lawyer has to say because they're all trying to avoid getting sued. And I'm like, it's not just about avoiding litigation. It's actually about eliminating birth trauma. Because if we have respect for maternity care, we've eliminated most birth trauma. And then we have a perinatal psychologist talk about from her insights and really that solution focus. Like, this is how, provide respectful maternity care. But she provides really fascinating and powerful snippets from women's stories, and they will just be in the clinical notes. Like, she'll screenshot. And I think it helps humanize what we're saying. Like, this is actually, you don't see the woman after discharge, but this is the harm that was caused from that interaction. So we've had really good feedback. We've actually got government funding in Queensland to deliver about 12 trainings a year. And then we went to Perth a bit over 12 months ago, about 14 months ago actually, and we delivered 10 trainings in a week there. So that was a very, very busy week. And then, we just travel around and do what we can, because I think, yes, I can help one individual woman, but if I can get this care provider on this same page, they might interact with 40, 100, 200 women a year. And that is so much more powerful if we're talking about ripple effects. So it's something I'm very passionate about. And it does mean that I'm on the road for quite a few weeks a year. But if that's the most impact, I think that's where I need to be.
It is a very powerful training. Like when we get trainings on, this is how you should act in a workplace when you are, before you start working, this is how you get, or this is how you should act. It's
Mm.
a powerful training. Um, and I was thinking, like, when we are talking about respect in working with the pregnant woman, respect also means that they can decline the suggested things that I am going to suggest them, like go into synthetic labor or go
Mm.
into caesarean, and they can decline. So I'm thinking, if a woman declines, who has now the duty of care, that if something happens to that woman, who's going to be blamed? Is it the woman or the medical structure or the doctor or the nurse? Um,
Yeah, well, the law's pretty clear. So as long as a woman's had informed decision making, and this is often where it comes unstuck, right? Because she hasn't actually had unbiased information. It might be trying to steer her down a certain path. But when we talk about informed consent, there's really two sides. So one's the information side, which needs to be unbiased, and that's another thing. There's often a bias put on it, but unbiased into evidence based. The other side is the decision making, and the decision is the woman's because she's a capable adult. She gets to make the decisions for her and her fetus, and that's just how it is. So she bears the responsibility of that, and that's not to be like hoping that women have poor outcomes at all, but that is actually how it works. And we know that from other areas of health. Say, for instance, Jehovah Witnesses, they get to decline blood products and they bear the outcome. But there seems to be this real sticking point in the maternal health space, whereas a woman makes a decision, and if we don't like the decision, when I'm saying we, I'm saying the care provider, that they seem to be able to think that they can override that. And that's not how it works at all. I mean, Jehovah Witnesses do it all the time. And I say this to staff, because they're like, well, what about us? And I'm like, well, actually, we've got a whole population, a whole religion that have actually set the precedent for this, and you guys are respecting their choices. We need to get to the point where we're respecting women's choices. And women make good choices all the time about their babies. Like, it is really dismissive of a woman's capability and intellect to say, no, I'm just going to override what you're saying or or your request.
I've got two questions from that. One is that we know that the medical fraternity is dominated by women, doctors, nurses, everyone. So why is that this huge gap where women can't understand what women want or what they're trying to give? Why is there so much
Yes.
gap?
Okay. So I think we need to, historically though, medicine was not ruled by women. That's only come about, like, it's swung the other way the last few years. We also need to, so when we're talking maternity space, it's often midwives and obstetricians who are the two main care providers in that space. Whilst midwives are very much trained to be woman centered, and often more supporting that physiological approach to birth, we've got to remember who's often set the rules of the hospital and the guidelines, and that's not the midwives. So we've got medicine that historically was very male dominated. It was also very much, and still is, the lens that birth is a medical event and you fluke it if you get a physiological event, as opposed to, like, birth's normal and natural, and if something goes wrong, then we escalate it. So it's a very different lens that we're looking through as well. I think the way, and this is coming from doctors that I've spoken to, like good doctors, have said that we've never really been trained to understand that concept of having that two-way discussion and letting the woman decide. It's like, this happens and this happens and this happens and this happens. So the clinical skills are valued more than the human skills, that humanizing care. So until we get that balance right, and the way, yeah, it's never really been a gendered thing, because if you look historically, it's still very patriarchal. I'm though seeing, I think, what would you say, some very encouraging interactions with our younger doctors. Like, I think they're starting to get it. Like, it was only a few years ago that if a woman was under like general anaesthetic, there would be student doctors coming in and doing whatever. Like, consent was not, consent was kind of a thing to do to women, as in, I get her to say yes, as opposed to consent should be considered more like an informed decision that that woman makes. So we need to get everyone on the same page, regardless of gender and regardless of who they are in that space, understanding that consent isn't a yes process. It is an informed decision process where the woman makes the decision, and they just have to sit with that. I think there's also the element of which professions are doing reflective practice. Like, at the end of the day, did I have that respectful dialogue with the woman? Did I override her decisions? Did I let her know that what I'm saying to her or advising her is not necessarily even based on evidence? It's based on some guideline or some hospital policy. I have to tell you this, but it doesn't mean that you need to accept it. And having that discussion, and I'll say to care providers during training, like, it's not just about you providing women with the information. You also need to explain to her how informed decision making works, because we've often been told that informed consent is about pretty much giving them a yes, and saying no is often seen as being difficult. And it is, and that's regardless of your cultural background. It's often been historically, if you say no, that you're being a difficult woman, or you don't have your baby's best interest at heart, or things like that. So getting women to even understand that is a little part of that as well. And that's why I say to care providers, you need to make sure that women know that that is how it works as well.
I had a very different theory of why this is happening. Uh, uh, and I think it is, I'll tell you and you tell me, is it correct or
Yeah,
not?
yeah.
Right. So, my observation in Australia in 10 years is that we get anxious as a population if something happens outside of what is not supposed to be happening. So there was knife attacks in Queensland, and then the state brought in sweeping knife laws. You can't do this, you can't do this, you can't do 100 things. There were knife attacks, one or two in WA, and they recently brought in knife attacks laws, knife laws. You can't carry, police can check you anywhere, whatever happens. The Bondi terror attack happens, and the government brought in huge sweeping gun laws. We'll take away everything. So basically, what I'm suggesting is that the government has this tendency that if something happens outside of normal, we'll try to control and prevent it. So in the birthing space, if there is something happens when a woman is home birthing or free birthing, or even in hospital settings, the government takes the responsibility on itself that we will manage this and prevent this from happening again, which means the bureaucracy and the policy and rules tends towards the setting and the structure and the public health system, rather and taking away rights more from the women. What do you think?
Yeah. Oh, listen, I think we've got very reactive policies. Absolutely. And it will be pretty much the next news, like media cycle. And so it's absolutely very reactive. I mean, I know it because that's why I utilise the media to do what I do. As in, you run a few things in the media and you'll get some results. It's interesting you raised that, because there was actually only a few months ago, two of the professional bodies decided to make a statement about free birth, and ultimately women get to decide, because they will bear the outcomes of that free birth as well. But what I found really concerning was the lack of self-reflection as professionals. So when you're going to the government and asking the government to regulate free birth or who's attending a free birth, you're not looking at yourself and why women are choosing to free birth, and they're actually opting out of your care, which is stuff about your care, and that's where you should be looking. So yeah, absolutely. We've got a very reactive space. It's interesting though, because I wish they actually reacted as quickly around birth trauma. That's one thing that it's like, because I'll often get, oh, things happen so slowly. I said, don't tell me that, because during COVID you locked the whole country down. That was not slow, that was fast. Like, everything was fast. I couldn't even go to a restaurant without checking in. You can do stuff fast if you want to. It really is prototype and optics. And so if something's getting bad press, or inversely, if they think they're going to get a political win out of something, they will do something very reactive. And these recent laws, I think they could have gone to consultation across communities, and it just, like, good laws take time to work up. Who has ever seen a good law that's kind of popped up overnight? It just doesn't happen. And I think no matter what political persuasion you're from, we really need a strong opposition to keep the government to account. And at the moment, the opposition are too busy eating each other. So, I mean, I'm quite conservative by nature, but I'm like, oh my God, this is embarrassing. Like, we want strong opposition to keep government to account, and at the moment we don't have it. So we've got a government that can just walk straight through and be quite reactive with their policies and their laws that they're putting through, without decent challenge, because the conservative side of politics are too busy eating themselves.
While you were talking about the respectful maternity care, you said, or you were talking about how the health professionals, individuals should review what they do, and like they can go back and think, did I did this right? Did I did this right? Like, health professionals are of all shades. So if there are health professionals who think that they should do better, but they are stuck in the system, what do they should do? Like, should they approach training like yours, or is there other resources that they can go to and better themselves and give more respectful care?
Oh, absolutely. And they don't even have to pay for training. There's that much free content online. Like the Respect for Maternity Care Charter, it was done by White Ribbon Alliance, which was an organisation it's still around some countries. It was very political and not great what happened in Australia as far as White Ribbon Alliance. But at the very least, the Respect for Maternity Care Charter is there. There are also like validated tools, basically self-reflection tools, that I think it's called the Midwives Knowledge and Practice of Respect for Maternity Care. So there are scales that they could print off and have a little bit of a look through. I think what I would say, and I have, at least every week, I have staff around the country calling me, asking me for suggestions, like good staff wanting to make change. And you're up against like trying to make cultural change. So I think absolutely have a plan, and it has to be little and often, because it's never going to be one and done. Like, oh, let's mention respect for maternity care on Monday and we revisit it again next year. It just doesn't happen. It has to be incremental. And I've seen some really good things done in hospitals, not just the training, but they will be doing other stuff, self-reflecting. They'll have the Respect for Maternity Care Charter up in the hospital. And that's not just for themselves, but I'm like, women need to know about their rights as well. They will have tools that help facilitate that conversation. Okay, have I... the very first thing, apart from introducing themselves, a care provider should do is see, does this woman need an interpreter? Because if they're not, I mean, honestly, if that woman needs an interpreter and they haven't got it, what the hell are they doing there? Because that woman is going to get railroaded into things that she doesn't understand and possibly doesn't need. And then, we've actually got a flow chart for them, which again is free, but this kind of stuff is really breaking that down for them. Have I actually thought about what my biases that I'm bringing into this conversational interaction are? And have I actually respectfully explored, what does the woman want? Because this is often not even considered. This, like, oh, you're here for, okay, here's your appointment, this, and this, we've ticked it all, catch you later. So just things like that. And there are absolute gems in our system who are trying to drive change. But I would say have a bit of a plan. Otherwise, you're really just throwing stuff at the wall and hoping it hits. Because we need, as much as we need like consumers advocating on the outside, we need good people on the inside doing it as well. I often say that to healthcare professionals as well, get some good consumers, because we can be your voice. So you can effectively tell us what's going on within the hospital, and we can take that to the MP, because the problem is staff often, because they're not protected and they'll lose their job, staff have a really hard time escalating some of these problem behaviours that they witness by other staff as well. So there can be a real collaboration between staff and consumers as well to make effective change.
It's so relevant that you mentioned about the having an interpreter, because there were a few children deaths in WA. Aishwarya was the one everyone knows about her, and then there was Sandeep and Dhar. The parents were
Yes.
telling, "This is happening. No one is listening." It's so relevant because the worst outcome of that miscommunication can be a death.
Mm.
Few children have died, mothers have died in WA system, all because of communication gaps. So it's so relevant.
And having visited there, like I from the East Coast, right? The way we get sold WA is that it's very white, and and I go over there, I'm like, we're sold a lie on the East Coast. It's very multicultural, and I was like, so why don't you have multicultural models of care, like where you've got like someone to interpret that's part of that model, so they have access to that care provider, but or I know there's organisations, like I know there's Indian organisations, so why are you not going to the community and saying, how can we better provide healthcare for you, whether it's in your community, as part of your community centres or whatever? Like, why are we making these communities go into the system that's obviously not safe for them? Like, they've proven it over and over again. It is not safe for the Indian community to go into the hospital because they're not being provided with interpreters, they're not being believed. It's just like, it's just a sad reality at the moment. It's not safe for them. So that's where the system needs to start providing that care that is safe, and that may mean providing, like, rethinking the way that we're delivering care and get it out in the community.
Looking at resources for respectful maternity care, I was looking at your podcast, which I don't know why you named it as Birth, the Forgotten Feminist Issue. And I was
Mm,
thinking, why is this a feminist issue?
mm.
And then if it is a feminist issue, where does it leaves all our men? Because every pregnancy or maternity care there is a partner who
Mm.
is doing all the background work, and where does it leaves him?
Yeah, so I guess why I named it the Forgotten Feminist Issue is because feminists forgot about birth. So remember, they were, and I'm
Right.
talking about very much the white feminist movement, right? They were burning the bras, they wanted to be equal to men, they wanted reproductive rights, okay? They wanted access to termination, they wanted access to contraception. Never was birth mentioned. And you know what it was about? It was about, because birth was seen as an issue. If we support birth, we must then support women being back in the home and homemaking. So birth was tied to homemaking. So that's why I named it that, because some of what I did when I was podcasting was really explore those issues. Like, why did the feminists forget about us? Like, because that is why I think we're so far behind in this space, is because we didn't have the bra burning for us like the rest of the movement did. The reproductive access really stopped at termination and access to birth control. Um, I do think men absolutely have a huge part in birth, because we see it all the time, is the fallout, and often the trauma that men experience, that bystander trauma is huge. And then you've got two parents with trauma trying to parent, and it's tough. I do think, though, dads not just are playing more of a role in supporting women during that period, but also on the other side, we're actually finding more dads coming to us wanting help making complaints about, because they can see that this was not right, and at the very least, to be able to support her going forward, I want to support, making that complaint and just take that burden away from her. I think absolutely dads have such a critical role, and if they understand a little bit about women's rights and that ability to say no and things like that as well, I think they can be a really powerful advocate for women as well.
Um, you mentioned about medical terminancy of pregnancy, and I was so I had no words to what's happening in Australia. Like in India, the you can medically terminate a pregnancy up to 20 weeks, and then after
Mm,
that, it's very difficult. You need
mm,
double medical opinions and 100 things to terminate a pregnancy. In Australia, I think there is a push to terminate up to 9 months or the last day. And
mm.
even if there is a live birth, you don't give medical support or caring support to it. So you let it die. And I'm thinking, like, what has Australia gone to? This is a beacon of human rights. And that fetus, that child which has just been born, is also a human. The most vulnerable in all that setting between doctors and mother and caregivers and parents and the child, that is the most vulnerable, the most person who can't speak for himself or herself, and he or she is not given any care. That's the proposal of some feminists. I just don't have any words on that.
Yeah, I find it very difficult as well, only because I know what a 9-month-old fetus looks like. Like they're very developed. They can breathe by themselves. It is very hard in Australia to get a termination that late as well. What I think needs to happen is, if we had, so some of it I think is why it's happening later is just an access thing, because ideally you want termination, like for those who don't want to carry pregnancy, you do want it to happen earlier because it is hugely traumatic to women as well. There is a portion of women who, for whether their baby is not compatible with life or it's for their own well-being so they can live, need to access termination, and absolutely that is hugely traumatic for them. I don't know the exact stats on the other reasons women are having termination, but it does beg a belief how it's getting so late in pregnancies that this is happening, because you are right. And I've had staff tell me that I haven't heard of one that's that late, but certainly like between 16 and 24 weekers, um, and they can't be given any assistance, and staff actually are finding it quite traumatic. So I think some of the solution is, and there have been things explored as far as being able to access, I can't remember the drug that it's called. So basically the tablet that you take very early in pregnancy. Some of the issue with that, and I think it's being, what would you say, addressed, is you can't access that until you have a scan. Now, if you can't get to a scan, so a sonographer, if you can't get to a sonographer, so if you're rural or regional, good luck with that. But also they're booked out. So I think this is some of this delay in care, is the woman may have accessed some service for the termination. Sorry, we can't give you the medication until you go for a scan. I can't get to a scan for another 6 or 8 weeks. So now all of a sudden we're, like getting well into pregnancy. It's the way that the law is written. If we start rolling back the woman making the decision, this is how it will impact the maternity space. So we need to have the full gamut of reproductive rights where that woman gets to make the decision for her and her fetus, because otherwise, and we see it already happening in the maternity space, what about the baby? And so things are done to women that they're not consenting to, being forced into procedure, like held down, being cut without consent, you name it, already, even though we've got laws that say that their fetus doesn't have rights. So it is a really, really difficult spot. What I would like to see is earlier access, and that may mean that we need nurses and midwives who are trained to do scanning, because I think that is actually a huge barrier and some of this delay. Because ideally too, women, it's easier to take a tablet than it is to then go in for a surgical termination. Like then you're under GA and the recovery time is longer and things like that. And I would imagine would be more traumatic. It would be interesting to see on that side of things, whether that, because until we have the data, we're still just making inferences about what's happening in this space. But I do know it is, staff are finding it. Because if you're a midwife, you went into midwifery to support. I mean, it's not that you're never going to see a stillbirth or a baby that hasn't lived, or a poor outcome. It's not that, but it's really about supporting women and bringing forth life. Okay, and some midwives don't have a problem with it, but they're absolutely midwives who do find it quite distressing having to support that. So I think perhaps staff may be able, need to be able to have choice in this. And I know it's been a big thing in private hospitals that they shouldn't get to decide. But ultimately, how are we supporting staff? Do they need counselling or whatever? Or do we need a certain cohort of staff that just deal with termination? And perhaps that is a way forward. Like, they've made the choice, they want to support reproductive access in that way. Because I think we've got midwives that went into the space that it's not that they don't support reproductive access, but they don't particularly want to be dealing with that all the time, because that would be traumatic. I think. And it's not that they're not supporting the woman, but having to deal with dead fetuses all the time.
There's another side to it, and a very horrific side to it. And I'll just briefly mention before we move on. I thought it's relevant here. India had very low sex ratio. Like, there's a social thing to kill the girl child because it's for various of reasons. And to counter that, the government brought in a regulation of sonography that the doctor can't tell you the gender of the child across pregnancy. So that was brought in. But now what has happened is it's just been reported from UK that the migrant communities there are still having that preference for the male child. And
so
because
they're
these
terminating the girls.
Yes. Because they have a preference for that. And even they are in UK, they still have that preference. And because they have access to these facilities and they can know the gender of the child, that's happening. And the sex ratio in the migrant communities is again skewed towards boys. And I have some indirect data that this is happening again in the migrant Indian, possibly Punjabi Sikh communities in Victoria. I don't have direct data, indirect, but that's why I haven't published. But I'm thinking that we're still going, that the moment we open up the access to sonography and gender data and all that, we're still going back to the same thing.
Yeah, that cultural, and I guess was quite ignorant to it. Even it's been quite fascinating, like being with a Pakistani, and some of the cultural stuff, like first cousin marriage is totally fine. I was like, oh, that's actually considered incest in the West, and you'll end up with a disabled baby. No, it's really good because you get the best genetics. I'm like, no, that's not what the science says. But it's interesting, the cultural stuff that just gets passed down and no one even questions. I think you guys are a pretty tight-knit community, like you would know if it's happening. I mean, we know that. I mean, I just saw an ad actually, and it was aimed at teachers, that child marriages are happening in Australia, and I'm mortified. I'm absolutely
Yeah,
mortified, but it makes
yeah.
sense. Like, I think sometimes, and I'm sure white people will come at me and say it's not true, but I think there is an ignorance that we think that just because someone's migrated, that the cultural stuff is no longer an influence, when it's not the case at all. Sometimes they actually are holding on to it even more. And yeah, I was quite mortified that we've got child marriages in this country, because it was a bit of a call to teachers, like, your responsibility is to keep an eye on this. And I was like, holy, it was never even a thing when that I knew of as a kid. But absolutely, I think that as we become more multicultural, it's something that we need to be aware of. I don't know how, in a country though where you have so much reproductive rights access, that you could be rein it in like they have in India, where you don't know. I think it's just education, that in this country, like, girls are considered just as valuable as boys. But I don't think that would be just India. I can't say that it's happening, but I definitely know even Pakistanis value boys more than girls too. And there would be.
That's a marker of a traditional family where the boy is valued more because of economic and other reasons. That's a marker of all traditional families. But child marriage, like when I came to Australia 10 years ago, there were news reports that some families, not to name any particular group, they were sending their children outside of Australia to get married and for other reasons.
Yeah. And and that's where we have to adapt our laws to the changing environment. Like, I know there was the female genital mutilation that was happening in certain factions of
Still
communities.
happening.
Well, yeah, even though it's outlawed, but we had to develop laws around that. We've actually even now got guidelines in the maternal health space to be supporting women with that, because obviously there's issues when they're, during childbirth and things like that, that staff have to be aware of.
You mentioned supporting women, so let's get into that. Um, for listeners who are pregnant and maybe thinking of getting a pregnant, what is the single most important thing that you would say they should know about maternity care?
I think, just let's be honest about knowing that we've got high intervention rates and high birth trauma rates. And it's never to scare women. It's just let's look at the cold hard facts here. Be aware. Know how birth works, okay? So if you're scared of birth, you need to deal with that. Birth, in my mind, is like a physiological event. So normal, natural, until it's not. I think just be educated, and particularly, if you're from a different cultural background, that you can say no and you have autonomy. And that may be, getting educated even about certain procedures and, what's the evidence behind it. Have those conversations too with your care provider. I would honestly say to women, if you can access a known midwife, do that. If you can access a doula, like a birth support, they can't provide medical advice, but they can certainly help with the emotional stuff. Access that, but have those conversations with staff too. Hey, what are your intervention rates? How do you go about supporting informed decision making? Because that will start to give you some clues about whether you're going to get resistance or got to get support from where you're birthing, or where you intend to birth. And don't be reluctant to have a birth plan. Like, I know there's a lot of just go with the flow. The flow will be the hospital's plan. That is the flow. They already have a plan for you. And it's often this cascade of intervention. So don't be worried about having a birth plan, but know what that birth plan means. And I think get educated even as a couple. And yeah, again, look for a known midwife if you can find one. And just don't. And I guess this is for people from other backgrounds. Don't disregard things like having a known midwife. Explore home birth. Like, if you're a low risk woman, you're actually a really good candidate for having a successful home birth, because you will actually have higher satisfaction and less intervention if you're that cohort of women as well. And don't be afraid to reach out to organisations like Maternity Consumer Network if you need help, because that's what our volunteers are there for, to help women navigate to get good birth outcomes too.
That's for the woman mostly. How
Mm.
can men and the family members can be better advocates standing side by the woman?
Absolutely, and it would be the same process too. Getting educated, knowing how that informed decision making works. There's actually some really good organisations too. There's one called like Prepared Dads, and there is specific childbirth education for dads, which really, and it's just for dads. So there's no, like, I sometimes find when partners will go together, dad might tune out a little bit to the childbirth education stuff because it's, oh, well, she's listening. She's good. She'll give you the notes later. Whereas there is actually specific education just for dads. So it's in a group of dads. There's also SMS for dads, which is it's just text messages, and it just reminds dads things about the importance of, like, the baby can hear you while it's growing within the mum's womb, and so they're getting more involved early on. And then just ways, and again, it's just like you get it via text, ways that you can help support baby or mum and things like that. So there absolutely are services that are tailored. Like, I think there's some stuff to do together, but I think there's absolutely stuff that dads can do by themselves to support their journey too.
So, if the woman is informed, as you suggested, and the men and the family are informed and they know things, how do you see the Australian health system, say, 15 years from now? What's the ideal system?
Absolutely, any family that wanted it should have access to a known midwife, and access to, whether they want water birth, whatever that is. We want more access to things like birth centre and home birth as well, but also care where the woman needs it. So when they're in rural or regional areas, they have access to that care, and ultimately enough obstetricians and medical staff that those women shouldn't have to transfer out of those if they're higher risk as well. Um, that would also, we need funding reform. And we've never, as I've said, we've never gone to a government and said, hey, we need more money dropped into that. We've said redistribute the money. And I think respectful maternity care. So I would love to see in 15 years very minimal birth trauma, very minimal. Like, any birth trauma that's caused from care provider interaction is eliminated, because care providers are providing that trauma informed and respectful, kind care that they should. Like, I honestly think that people get treated better in palliative care than they do during birth, and I think that's terrible. Like, it's disgusting that that's how women are treated. So I think that would be my three things in 15 years. Like, when I'm a grandma, that's what I would like to see, basically. When my eldest daughter's having kids, because I'm mortified at the prospect that in 10 to 15 years, I've got my first daughter staring down the barrel of childbirth, and I'm scared for her because of what the system's like.
That's a very scary language of staring down a barrel. Um,
It honestly, the way women describe it when they've been mistreated, it almost feels like that.
so, if your daughter wants to reach out to MCN, or any other woman or anyone wants to reach out, how they can reach out to you or MCN?
Yeah, absolutely. Like, we've got a Facebook page and Instagram. We're not really across much other social media, and via our website. So Maternity Consumer Network, all one word, .org.au. And there's a form there that they could contact. But we've also just got some general resources too that's worth having a look through.
Um, Hoping all that thing that you look forward to materializes, not in
Yes, me
15
too.
years, but
No,
possibly 5 years,
that would be
10
great,
years.
wouldn't it?
Yeah, that'll be good. And on that positive note, I'd like to thank you for the time that you're given and the work you're doing.
It's I don't. It's funny. I never thought I would be spending half my week volunteering to do this, but it's very rewarding, and I think we all should really, if we actually all had an attitude of service, I think we'd actually manage to transform this space. So it's, yeah, I kind of fell into it, but it's worth it when women have better outcomes.
All right. Thank you, Alicia. Thank you so much.
Thank you.